Okay. In this video, we'll discuss about thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura is a rare and life-threatening thrombotic microangiopathy characterized by microangiopathic hemolytic anemia, severe thrombocytopenia, and organ ischemia, which is linked to disseminated microvascular platelet-rich thrombi. TTP occurs due to severe deficiency in ADAMTS13, which is a protease that cleaves the von Willebrand factors. TTP can be classified into immune-mediated TTP and congenital TTP. This immune-mediated TTP occurs mostly because of the anti-ADAMTS13 autoantibodies, which inhibit the proteolytic activity of the ADAMTS13 towards von Willebrand factor. And this immune-mediated TTP can be further classified into primary and secondary TTP. Female gender, black ethnicity, HLA-DRP1, and obesity are the predisposing factors for the development of TTP. And similarly, some infections like HIV, pregnancy, and the inflammation can precipitate TTP. Talking about the epidemiology, it's a rare hematological disease with annual prevalence of 10 cases per million people and annual incidence of 1 new case per million people. It mainly occurs by autoimmune mechanism. However, rare inherited forms can be present, and it's more common in women. And this congenital TTP, it occurs more in children in pregnancy. Clinical course is characterized by a relapsing tendency, and the mortality rate is 10 to 20% in spite of appropriate therapeutic management. Congenital ADAMTS13 deficiency or congenital TTP is also known as Opsa-Skallman syndrome. It's autosomal recessive disease due to the biallelic mutation in the ADAMTS13 gene located in chromosome 9q34. Immune TTP can be further classified into primary and secondary. So in primary TTP, there is no obvious underlying associated disease, whereas in secondary immune TTP, there can be underlying diseases like infections like HIV, influenza A, Legionella, hepatitis C are associated with secondary TTP. Similarly, pancreatitis, drug like ticlopidine, and autoimmune diseases like SLE has been associated with secondary TTP. Now let's discuss about the pathophysiology. In the physiological conditions, these ultra-large von Willebrand factor multimers, which are released from the endothelial cells, are cleaved by this ADAMTS13 into the smaller von Willebrand factor multimers, which are less adhesive to the platelets. But when there is deficiency of ADAMTS13 or there is autoantibodies against ADAMTS13, these circulating ultra-large von Willebrand factor multimers cannot be broken down into the smaller von Willebrand factor multimers. So these ultra-large von Willebrand factor multimers, they bind to the platelet and form aggregates within the artery and the capillary microvessels, which lead to the tissue ischemia, platelet consumption, and microangiopathic hemolytic anemia. For the diagnosis, history is very important. Historical clinical pentad, which has been used for the diagnosis, include fever, thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms, and the renal insufficiency. However, this is present in less than 10% of the patients and no longer used nowadays. So the presence of thrombocytopenia in the microangiopathic hemolytic anemia alone without alternate explanation should always prompt serious consideration of the diagnosis of TTP. Patient can present with the features of anemia like weakness and dyspnea, or patient can present with the features of thrombocytopenia like skin and mucosal hemorrhage. Sometimes patient can present with features of jaundice, and patient can present with the features of the organ ischemia or infarction, like patient can have headache, confusion, stroke, coma, or seizures. Patient can sometimes present with myocardial infarction and heart failure. Sometimes there can be abdominal pain and diarrhea due to the mesenteric ischemia, and similarly there can be proteinuria and hematuria as well. Differential diagnosis is broad. We need to consider all other thrombotic microangiopathies as a possible differential diagnosis. So hemolytic uremic syndrome, pregnancy-associated thrombotic microangiopathies like HELLP syndrome, preeclampsia, DIC, malignant hypertension are the important differentials. Similarly, TMAs related to the cancer, organ transplantation, sepsis, drugs should be ruled out. Similarly, Evans syndrome, isolated thrombocytopenia, isolated hemolytic anemia, and ischemic manifestations linked to the autoimmune disease like SLE, ITP with APLAS should be considered. So the screening for ADAMTS13 activity is the first test to be performed. And if the activity is less than 10%, diagnosis of TTP is confirmed. So the subsequent investigations should be aimed as documenting the mechanism of this ADAMTS13 severe deficiency. So we need to perform the assays for the ADAMTS13 autoantibodies. We need to search the ADAMTS13 inhibitors, And in certain cases, we might need to perform the ADAMTS13 gene sequencing as well. So this picture shows the approach to the investigation using ADAMTS13 assays. When there's suspicion of acute TTP, we should perform the ADAMTS13 activity test. And if the activity is more than 10%, we have to think of the other diagnosis. If the activity is less than 10%, it confirms the diagnosis of TTP. So after we confirm the diagnosis of TTP, we need to perform the anti-ADAMTS13 IgG autoantibody testing. If it's positive, it is suggestive of autoimmune TTP, and if it's negative, then we have to follow a patient with the ADAMTS13 monitoring. Then we have to measure the ADAMTS13 activity in the remission and anti-ADAMTS13 IgG during relapses. If the level is always less than 10% and always antibody is always negative, then ADAMTS13 gene analysis is done. And if there's mutation, inherited TTP is diagnosed, and if there's no mutation, TTP of unknown etiology is diagnosed. Other investigations might include CBC to look for anemia. There can be thrombocytopenia. In blood picture, patient will have these crescent cells, helmet cells. There can be the features of hemolysis like elevated reticulocyte counts, low or undetectable serum haptoglobin, elevated LDH and bilirubin. Similarly, serum creatinine and urine RE is done to rule out renal involvement. ECG is done to rule out cardiac involvement. ANA is done to rule out SLE, and Coombs test can be done, which is usually negative. So now let's discuss about the treatment of TTP. Acute TTP is a clinical emergency, and the frontline treatment should be started prior to confirmatory ADAMTS13 testing. So the treatment can be started based on plasmic score. It's a clinical prediction score that predicts the severe ADAMTS13 deficiency in hospitalized patients with suspected thrombotic microangiopathy. So this is the plasmic score. In plasmic score, the variables which are used include platelet count, hemolysis, active cancer, history of solid organ or stem cell transplant, MCV less than 90, INR less than 1.5, creatinine less than 2.0. If the total score is above 5, then patients should be empirically treated for the TTP unless there is an obvious alternative explanation for the individual's clinical presentation. So before we get the results of the ADAMTS13 activity, we can start the treatment based on the plasmic score. So before starting the treatment, we need to understand definition of the treatment response. Like clinical response is defined as the platelet count above 150,000 for consecutive days together with normal or normalizing LDH and clinical recovery. Similarly, clinical remission is a clinical response lasting for at least 30 days after discontinuation of the therapeutic plasma exchange. Exacerbation is defined as recurrent disease within 30 days after reaching the treatment response. And relapse is defined as the recurrent disease 30 days or longer after reaching the treatment response. And refractory disease is defined as no treatment response by day 30 or no durable treatment response by day 60. So this therapeutic plasma exchange is the cornerstone of the TTP management. The mechanism is that plasma supplies the adequate level of the ADAMTS13 while removing the circulating anti-ADAMTS13 autoantibodies. So the dose is usually 1 to 1.5 times plasma volume exchange for first 3 days, followed by 1 time patient plasma volume each day thereafter. So this plasma exchange is performed daily until the features related to the organ involvement have resolved, platelet count has stably recovered, and hemolysis has ceased. In case of the refractory disease, plasma exchange can be done twice daily. Steroids are used in conjunction with the therapeutic plasma exchange at the initiation of the therapy. High-dose prednisolone is more efficacious than the standard dose of the steroid. However, most of the standards of the practice recommend oral prednisolone 1 mg per kg per day or equivalent, gradually tapered over 3 to 4 weeks after clinical response. However, the use of the steroids is still controversial. Rituximab is a humanized anti-CD20 monoclonal antibody, and it's indicated in the use of TTP. It can be used as a first-line treatment during acute phase, or it can be used in the patients who have suboptimal response to the TPE. Similarly, we can use rituximab in cases of the refractory disease and during the exacerbation of the disease. The benefit is that it results in the lower relapse rate and it reduces the mortality. The dose is 375 mg per meter square, given weekly for a total of 4 doses. Other immunomodulators like vincristine, cyclosporin, mycophenolate, and cyclophosphamide can be used in cases of the refractory TTP and when there's contraindication to the use of steroids. Splenectomy can be sometimes used in the acute life-threatening cases, and it can also be used in the prevention of the relapse in the chronically relapsing cases and in the refractory cases as well. Bortezomib is a relatively new drug, which is a proteasome inhibitor which aims plasma cell depletion, and it can be used as an alternative agent to the rituximab in TTP patients. Caplacizumab is a humanized immunoglobulin targeting the A1 domain of von Willebrand factor. It inhibits the von Willebrand factor glycoprotein 1b interaction. Initial dose is 10 milligram given IV prior to the first therapeutic plasma exchange, followed by the 10 milligram daily and subcutaneously thereafter. Benefit is it significantly reduces the time to the platelet count normalization and the exacerbation rate when used along with the therapeutic plasma exchange and immunosuppression. Whereas the disadvantage is this needs to be continued for the long term because it only prevents the aggregation of the platelets and doesn't treat the underlying disease. Next treatment which can be used is the N-acetylcysteine. N-acetylcysteine degrades the ultra large von Willebrand factor multiple strings and inhibits the von Willebrand factor dependent platelet aggregation and collagen binding, so it can be useful in the TTP. Recombinant ADAMTS13 can also be used in the treatment of the TTP, and it's shown to be effective in both congenital as well as the immune TTP, and the evidence is evolving regarding the use of recombinant ADAMTS13. So to prevent the relapses, we can use rituximab, splenectomy, or the immunosuppressants like cyclosporine. So this chart shows the approach to the management of the adult onset acquired TTP. When there is adult onset acquired TTP, standard treatment of acute TTP with the therapeutic plasma exchange is started along with the steroids in emergency until remission. And if there is complete remission, then patients should be kept on the follow-up with a medical consultation and ADAMTS13 monitoring. And if there is relapse, then we can proceed with the management of the relapse. However, if patient doesn't respond to the initial treatment with the therapeutic plasma exchange and steroid, rituximab can be added to the treatment regimen. And then if patient attains the complete response, then patient should again be followed with the ADAMTS13 monitoring. And if the remission is durable, we can consider preemptive rituximab to prevent the TTP relapse. So the long-term complications of the TTP include the obesity related to the steroid use. A patient can have long-term complications due to the organ ischemia, like patient can have stroke, hypertension, mood disorders, cognitive impairment, and the overall reduced quality of the life. Now let's talk about the prognosis. With the prompt initiation of the therapeutic plasma exchange, the average survival rate from a first episode of TTP is 80 to 90%. However, the overall mortality is 10 to 20% in spite of appropriate therapeutic management. And the old age, very high level of the LDLs and increased cardiac troponin level are associated with death and treatment refractoriness. So these are the references which we used while preparing our video. Thank you so much for watching. Please subscribe to our channel for more videos.